Welcome to our presentation on understanding pain. I'm Heather, the nurse consultant with the Pain Management Service. I can't even do it without laughing.
That's fine.
Oh, man. All right, so the whole concept of why we wanted to put these pain lectures together is really looking at pain from a different angle. You know, we're so geared towards the medication route and interventional route, and although those are important and they do provide benefit in certain situations, but we forget about the person figuring out the underlying cause of the pain, because a lot of times if we do that, we don't necessarily have to do anything physically or interventionally. Oh, there it is. Sorry.
There you go.
Yeah. Okay. So we don't have any disclosures together, us. So like I said, we're going to talk about the overview of pain, the response to pain, and reframing the pain experience, meaning understanding what the patient is going through and moving forward as to how we can help them mentally, physically, emotionally. You know, pain is not just a physical response. It's an emotional response. It's a physiologic response. And then looking at how pain neuroscience education can really manage pain in a different way, reframe the experience, and really help people live better lives. But as we start talking, you know, pain by definition, from textbook definition, is an unpleasant sensory and emotional sensation associated with actual or potential tissue damage. And it says actual or potential tissue damage because when you think of pain, it's not just physical, I stubbed my toe, I got in a car accident, but emotional, like after a death in the family, or you go through a divorce and that emotional pain, you know, that years and years people experience different types of traumatic events, whether physically or emotionally, you know, that causes damage. And sometimes people that may have something emotional happen then in turn have physical symptoms that manifest from that. But everyone truly experiences pain in a different way. So some terminology that you hear through the literature is pain threshold and pain tolerance. So at one point that everyone experiences pain. So if I, you know, stub my toe and you stub your toe, we're both going to feel some level of discomfort. So that threshold, that the pain experience is real. Now, pain tolerance is the variable point. So I may stub my toe and rate it a 10 out of 10 and want to fall over because it hurts so bad. You may stub your toe and just keep walking down the street because you're like, Heather, that really wasn't that bad, you know. But what plays into that is our cultural background, religious background, environmental factors. So people, you know, that we've seen within the hospital system and even our geriatric population, sometimes they're very, you know, steadfast, very stoic in ways that, you know, they go through major surgery and they, you know, come out, yeah, I have a little pain, but not really. And then, of course, you see the people with, you know, minor surgery, the pain is a 10 out of 10. You can't even rationalize with them. But that all comes from, you know, different things that we've experienced in the past. Maybe that person that had that minor surgery, even though they're saying their pain is a 10 out of 10, maybe before they had a bad experience with surgery. I've had a couple people that had traumatic experiences where they woke up during surgery or felt like they had different, you know, experiences in that way, which caused their post-op experience to be worse. So finding out the underlying reason helps us treat pain more effectively and treat the patient more effectively. So instead of that minor surgery patient with the 10 out of 10 pain, giving them Dilaudid and oxycodone, now that we found out they had a traumatic experience with their prior surgery, we're helping them emotionally deal with that and understand. So this is kind of what I started getting into as far as a psychological or psychosocial, social, culture, and cognitive. The big thing here to remember with cognitive is we have a lot of patients of advanced age with dementia or even patients with TBI. They perceive pain differently because they're, structural, possibly inflammatory changes in the brain, depending on, what was the cause. And really how to look at pain-related behaviors, what they're doing physically, are they just staying in bed all day, but prior to they were at least up and out of bed, what is the whole concept here? And we've also seen patients in the hospital with different religious backgrounds that didn't want to be medicated at all. And as a provider, you want to instill comfort and to help someone. We had a lady quite a few years ago, bedridden, and probably stage 3, 4 ulcers between her because she was so cachectic on her spine and her sacrum, and they just didn't want anything for pain. I mean, it was hard because you have this sort of internal conflict where you can see the pain on her face. There was changes in her vital signs. She was visibly uncomfortable, but their personal belief, they just didn't want any pain medication or anything to alter her, and you respect that, but then you're looking at other ways to provide comfort. So So that was a great example of kind of summarizing and kind of leading into our next points of the discussion as far as really understanding the patient. You're looking and listening at what's going on, the emotional impact as well as the physical impact of the pain. But in that case scenario, we listened to the patient and did some restructure as far as the whole pain experience and what it means to them. You want the patient to be involved in the care, believe they can do it, and empower them to almost break that barrier. So really understanding the patient allows you to move forward and treat the pain. A lot of times in the hospital, we sort of, I think, miss that step. You have 10 minutes with your patient, you're trying to move as quickly as you can, but taking those 10 minutes, sitting down, saying, how do you feel? And really understanding why they feel the way they do makes more of an impact than offering a pill or doing something physically. I've done patient consults where I spent now maybe 45 minutes in the room with a patient. And I have offered no medications, no treatment. And when I left the room, they felt 10 times better than when I first came into the room. So it's really taking that time and acknowledging that, yeah, your pain is real, physically, mentally, emotionally, whichever it may be. That provides more relief than just saying, all right, I'm going to give you some more pain medication before I leave here. And in that process, you're allowing the patient to self-reflect and acknowledge and examine as to why they feel the way they do. Yes, that patient had physical, burns on her face, which are healed. She is healed, but that trauma and the pain experience is still real. But helping that patient work through that to move forward and support them in that process. Now, as you're going and understanding, it's not that you're going to go in, one time and always make monumental changes. That was a great example of the whole process. Some people need baby steps. So as you're talking to them, you feel and evaluate where they're kind of at and how to move forward. And sometimes it's just slow, making that introduction, setting some expectations, and just evaluating the situation. Our whole goal really is to improve their pain, but overall their quality of life and level of function. So another case. So that experience, for that patient, the pain in her back was real. So the more they talked to the patient and evaluated why she was feeling the way she did, came up that traumatic experience about her husband and the funeral. But the sad thing is, you heard at the beginning of the podcast, people labeled her. So that's the other part of this. Yes, every pain experience is real, but till we take the time to get there, we find out that people are labeled as having it, that they're crazy, that they can't really be experiencing pain, they just want drugs, they're pill seeking, yada, yada, yada. But finding out the underlying cause and treating that, or helping the patient work through those, made more of a difference, and she was able to get back to work and function. So as we're talking to patients and figuring out why we need to, or what's meaningful to them, is really helping them think through the experience, identify even like what's important to them, cultural, religious, that all play into how they perceive pain in the experience. But also help them identify what limits them, what are their fears, what are their personal goals and expectations. As the treatment provider teams, sometimes it's really helping reframe and manage those goals and expectations. Not in the sense of we're telling them what their goals are, but just helping them clarify to what makes sense for them to get the best outcome. So overall, part of this too is we need to be comfortable with people in pain. Not that trigger response as, oh, the patient's in 10 out of 10, what can I do immediately? It's okay. We need to look at our own triggers and what makes us uncomfortable about people in pain and not go right to we just have to do and do and do instead of evaluate and listen and understand. Therapeutic communication is going to be your tool in your back pocket to do this. Now, treatment options, are always in the picture, but something medication-wise and interventional doesn't always have to be, the be-all, end-all treatment. So, changing the perception. Pain is an experience, that affects the brain, the central nervous system. So, changing the perception is important. Recognizing the individuality of pain, that it's different for everyone and why it's important. And really utilizing our entire team to help treat the patient most effectively. So any questions on that portion?
Sorry. No, it's fine. So Heather's right. Every patient is different, and every office visit can be very, very different. I'm here to provide a little dose of reality. This is all well and good. This is awesome, but something can be done for these patients, and not simply by cutting off their opioids and just saying, hey, have fun. You don't know what else to do with them. So we all have choices, and usually it's one of two situations. You either have the patient that puts up the walls or the patient that all of a sudden those walls come crashing down. So I'm sure you know this situation, even in med school or physician practice, it's at the end of your visit, you're late for your next patient, your hand's on the doorknob, and the patient's like, oh, hey, doc, one more thing. I'm out of pills. Can you give me a refill? All right, so now you're in this one situation where, if they may have had a really complex surgery, and yeah, it's the right thing to do to give them more pills. But they also might have a problem that's really, you think really doesn't make sense to be that painful. You also they might have had a simple procedure. You're like, this doesn't make sense. Now, even if it doesn't make sense to give them a script, you also know that if you want to get out that door, the easiest thing to do is write the script. That's just reality. Because if you decide to stand your ground, they're usually going to go through about 4 different stages. First, and I know you know what I'm talking about already. First, it's going to be really confusion. It's going to be like, wait a minute, it's your job to manage my pain. You did this procedure on me, or you're managing my condition. That's your job. That's what you're supposed to do. All right, so if you explain to them about, that's not the normal thing, and, you don't do this for your patients, then they're like, wait a minute, but doc, I have this fibromyalgia, or I have this chronic knee pain or back pain or X, Y, and Z. I have this disc that has been causing me pain for years. I don't respond the same way as other people. My other doctors tell me I don't respond the same way. So they start manipulating you medically. So then if you stand your ground yet again, then they start to manipulate you emotionally. They're like, I thought you were different. I thought you cared about your patients. I guess I had you pegged wrong. Now if you stand your ground again, then they start to get pissed off. And then they start to throw out the complaints. So now you're spending even more time, and really no one walks out of that door. No one walks out of that door happy. Or you may have that patient where all the walls come crumbling down. So this is a situation where Dr. Adam Ryan, he's an OB-GYN in the Upper Peninsula of Michigan, and he just describes this situation where when patients do. So now the good news is you really don't have to go to an elaborate conference just yet. You can actually get a lot of useful alternatives right here in the Lehigh Valley. So those alternatives to opioids and aggressive pharmacologic management, we can learn about them. So to do this, first we'll delve into a very brief video that I really like to show my patients. It's actually really easily to find on YouTube or on Google. It's quick, it's entertaining, they have great Australian accents, and it's actually very informative. All right. So, how do we retrain the brain? Well, early work by Dr. Louis Gifford indicated the need for a much broader view of pain. Over the following decade, and this isn't that long ago, over the following decade from the 1990s to the early 2000s, a series of articles on pain mechanisms provided us with a broader view of pain and better understanding of the bigger and more biological view of pain and pain processing. However, some of these concepts are paradigm shifting. And while they're logical and clear, it has resulted that either most providers don't know about it, or providers have actually underestimated the ability of their patients to understand it because we don't fully understand it. This whole paradigm shift, it's completely different than some we would have learned in med school or PT school or nursing school 20, 30, 40 years ago. And that's actually been demonstrated in a research study in 2003 that was published in 2003. Providers really underestimate the ability of their patients to understand pain. So the first official published study involving neuroscience education was in 2002 by Dr. Lorimer Moseley. The aim of that study was to educate patients about pain and defocus on anatomical issues. Since then, Moseley and a number of other authors, especially Dr. Lowe, published dozens of randomized controlled trials, case studies, and case series on the use of neuroscience education in chronic low back pain, chronic whiplash, chronic fatigue syndrome, CRPS, joint arthroplasty, pre- and post-lumbar surgery, and among others. So it's amazing, and I've definitely been guilty of this. When a patient walks in my office and says, "Hey doc, my back hurts," I diagnose the problem, and then I start explaining the structure of the spine to the patient. Makes sense, that's what I learned in school. This might be fine for acute pain, but when the patient has heard this before and not improved, do you really think having them hear about the structure of their spine one more time is really going to set them at ease? I mean, you really think about it. It doesn't make sense. In fact, we've actually found through research that this doesn't happen. In fact, it generally makes patients more fearful and more painful, even in acute situations. So it sounds so simple to say, but it took the medical community till the early 2000s to discover that patients really want to know more about pain, not anatomy. So with all this surrounding attention surrounding this novel approach, what patients want, it would be nice to know if it actually works, because patients also seem to want opioids, and we all know how that has ended up. So in 2011, a systematic review of pain neuroscience education was conducted for musculoskeletal pain. At that time, they found 6 high-quality randomized control trials, 1 pseudo-randomized control trial, and 1 large comparative study. So what they found was that for chronic musculoskeletal pain disorders, there is compelling evidence that an educational strategy addressing neurophysiology and neurobiology of pain can have a positive effect on pain, disability, catastrophization, and physical performance, and that it may be more advantageous than traditional biomedical approaches. So further studies since then have demonstrated similar effects in reducing pain and disability that actually lasts. So this is not a temporary fix. In 2005, Moseley did a study looking at patients with chronic low back pain. The study utilized functional MRI to analyze brain activity during painful experiences. And I'm sure you're all aware, functional MRI measures changes in blood flow of the brain. And since the brain is such a blood-hungry organ, it's very useful at accurately translating to brain activity. Also, as I'm sure you're aware, research has shown that there is no one specific pain processing area. In fact, each pain experience is created with its own unique neural synaptic pattern based upon the repetitive pain experience and those inputs from sensory, motor, emotional, etc. This is a view of one of the patient's functional MRIs from the study. This patient had ongoing pain for years, specifically this patient, low back pain. They've been given various explanations for their pain, but the treatments weren't really helping. So row 1 is the patient resting. And I'm not sure if you're aware, but with functional MRI, it has to be calibrated. So they're in there, they're resting. That's the calibration, that's 0. Okay? So you can see the brain is calm, no red blobs. That's activity. Row 2, patient's asked to move her painful back. You can see what's going on here. It's going nuts. Shows us her brain is processing the pain experience. So then she's taken out of, she's provided with a pain neuroscience education session. It's about 2 hours or so. And then she's rescanned. The exact same motions. Drastic decrease. There is no physical intervention, no medicinal intervention. It is the pain neuroscience education only. This was the first time that we were actually able to see it. Every time before that, it was subjective reports, which, can be argued against. Now, because pain is so subjective, they did also do a numeric pain rating scale and a function, patient-reported functional outcome. And they both significantly improved as well. So it's not just on the functional MRI. The patient actually cared, too. And just in case you were concerned that this was a fluke, or that only Aussies could do this in the early 2000s, Lowe and Puentedora repeated this study in 2014 in the US and found the same results in patients with radiculopathy. In fact, many of the patients in 2014 no longer were looking for surgery for pain. They were looking for surgery to get rid of that foot drop, which, believe it or not, is exactly why we want to do lumbar surgery in the first place, to get rid of the neurologic impingement. Period. It's not very effective for pain. It is extremely effective for neurologic impingement, though. So they actually got the surgery for the right reason. So now you're probably asking yourselves, how can this be done? Is it a single intervention, or is it performed on a series of multiple occasions? So as a physical therapist, I have the luxury of seeing many of my patients on multiple occasions. This can and has been performed in a single session, but is much better to be performed methodically over a series of sessions, especially because they're at a very sensitive spot in their lives. And we also know that humans only absorb about 7% of what they hear. So you'll also see some repetition in some of this pain neuroscience education, although you may not remember that because you only pick up about 7% of what I say. So, here we go. The first part is really just understanding the nervous system. So, it's well established that most tissues in the human body heal within 3 to 6 months. And persistent pain is more likely due to changes in the central nervous system and the brain. During injury or emotional response, the body's nervous system activates, increasing its activity, and in some people, in about 1 in 4 or 1 in 3.5 people in the United States, the nervous system remains extra sensitized. The extra sensitization, either peripheral or central sensitization, impacts function considerably. When pain limits movement and function, patients may think something must be wrong. Giving them this different paradigm to understand pain, for the pain that's limiting their function, sensitive nerves versus tissue injury, is a powerful way to get patients to re-engage in activity, movement, and exercise. And many providers have heard it. It hurts when it's cold out. My pain gets worse when I'm stressed. It's interesting. The traditional old biomedical models of anatomy, biomechanics, and pathoanatomy are ill-equipped to explain these phenomena to patients. In fact, there's actually research showing that changes in weather do not change tissue. Yes, that's correct. However, explaining the neuroscience of ion channel neuroplasticity and sensitivity on a patient's level allows them to understand their pain better. Knowing that stress chemicals, stress hormones in the human body and or cold temperatures may result in increased awareness and even the pain experience, and that it can be explained and changed for the better, not only helps calm the patients, but it also provides hope. The ion channel explanations are timely in that they merge well with the use of membrane stabilizing drugs and antidepressants in people with pain. So, next, what does it mean when pain spreads? Does it mean more injury? In people with pain, this is exactly what they think. The increased peripheral and central sensitization, along with powerful changes in the brain, often leads them to experience spreading pain. Undoubtedly, this increases the fear and anxiety dramatically, as well as pain. Teaching patients the neurobiology of an inquisitive nervous system, along with its cousin, the immune system, allows patients to see the logical, biological systems seeking to protect them. Understanding that protection mechanism of the alarm system of the nervous system, looking to protect them, and understanding that there's no real threat to that, understanding that it's normal and can be changed, again, provides them with better calming understanding and hope. Then the number one question is, how do I calm them down? And this is the question all providers want their patients to ask, because it's the right question. Versus, how do you fix this for me? Now, how do you fix it for me? That's not the right question in this chronic type of situation. Again, it's a lot of self-understanding and self-management. So we systematically describe various strategies we can use to steadily help calm the nervous system, which ultimately results in decreased pain and disability. This powerfully reframes therapy and for a patient provides hope. This exciting message of desensitization empowers the patient. It offers various strategies for them to actually do something with it to help them with their recovery. We then also go into some metaphors, because again, we know that people's understanding of anything is only going to be hurt or helped based upon a framework of what they already know. So you're really only going to internalize things that you have some sort of framework. Either that or you're going to modify that understanding to fit a framework of what you understand. So we utilize a lot of metaphors in this training because really that's how people will understand. So the first thing is people start saying, oh, you think this is all in my head. Really, we do hear this a lot. And this mindset is based off of a very outdated Cartesian model of pain. Did you learn about the Cartesian model of pain? It's basically where pain is falsely seen as physical or psychological. And by psychological, it means not real. That has been proven false many, many times. However, that's still what people think. The challenge for any provider is to bridge this gap. Bring the brain into the discussion without conveying the message that it's all in your head and that it's not real. So, having the patient see that tissue injury and pain are not the same, and that pain is a decision of the brain, is very, very powerful. And it's resulted in meaningful shifts in clinical practice. Also, the general theme of pain neuroscience education is making unknowns known. So various issues that patients struggle with, memory loss, problems with focus and concentration, fine motor control disability, food taste, body temperature, and more, can be discussed utilizing the pain neuromatrix. This teaches patients how a brain dealing with pain uses areas designated for other primary tasks at a cost. You can't use it for two different things at once. When brain areas are used for processing pain, primary tasks often suffer. When a patient understands why they may be struggling to perform small motor control tasks, for example, they will have less fear and frustration. They'll start to understand. They won't worry so much, which can lessen their pain experience. Another useful metaphor is talking about the brain as the CEO of the body. It's really useful for helping to explain central sensitization as well as spreading pain. It lets you reinforce that the brain is involved in body functions and that body parts report to the brain and pain is an output of the brain. Now, pain is only one of the outputs the brain uses to help protect us. When confronted with a threat, the brain also engages various other systems. And when pain persists, various systems that are helpful against short-term threats are continually engaged by the brain via stress chemicals like adrenaline and cortisol, which can have a tremendous impact if you're always ramped up on adrenaline and cortisol. Just think about it. Inject that into yourself constantly for years. What are you going to feel like? This metaphor powerfully illustrates and describes the protective mechanisms of the body and helps patients understand the various issues with which they're dealing. All right, and then we get into the hard stuff. When patients really start to get it, they naturally go into rejection. This pain stuff might sound good, but you don't understand. I have a disc, or I have a bad knee, or I have the worst back this doctor's ever seen in their entire life, because that's what they've told me. And by the way, that's a common phrase that I encourage you never to use. This may be the most common phrase uttered in clinical practice when trying to change a patient's cognition about their pain. Patients are indoctrinated in their tissues, and quite rightly so. We as medical professionals have been doing this for years. Of course, let's not forget the power and the evidence of a scan. So having the proper ammunition to persuade the patient to think differently about that bulging disc or rotator cuff injury could be enough to open their mind to a new way of thinking about pain. Now, this information needs to be delivered with tact and caution. We are not aiming to make a patient think nothing is wrong with a particular tissue. Okay, again, I rephrase that. We are not trying to say nothing is wrong with that tissue, but we are trying to say, we're trying to illustrate how bad tissues don't always cause pain. They're not the same. And that tissue issues are only one part of the pain experience. And finally, they want to understand why some of that funky stuff always seems to happen to them. Essentially, they want answers. And honestly, with the newer research, we can start to provide some answers for them. So we discuss topics like neurogenic inflammation. So following an injury or surgery, pain and swelling are expected, right? Makes sense. Having a joint remain swollen for months after the injury or surgery will undoubtedly cause more stress and anxiety. Teaching a patient how nerves send messages toward the spinal cord, orthodromic impulses, and towards the tissues, antidromic impulses, helps them understand neurogenic inflammation. An unhealthy nervous system, physically or emotionally, can keep tissues inflamed. We have some really cool stories about this that really help solidify this. But armed with this information, you can target strategies to help decrease nerve sensitivity to help recovery. Now, on the cutting edge of our understanding of pain via graded motor imagery is the primary somatic sensory cortex. Neuroplasticity is alive here. Body maps depend on movement and use, and in people with pain, decreased use of body parts and various other complex biological processes, such as neglect and the blood-brain barrier change these body maps. This has far-reaching implications for people, often on the severe end of the pain spectrum, such as CRPS and phantom limb pain. Then we talk about immune system and emotions. Recently, a lot of research has been focused on the immune system. How the immune system works in pain is interesting, and it allows for yet another paradigm to help understand issues like spreading pain, old pains coming back, and pain increase during the flu, and more. The immune discussion allows for a widespread plan of attack on pain and gives you added ammunition to drive home the importance of exercise, sleep, movement, coping, diet, relaxation, medication, and more. Okay? All in contrast to other models of fix me. Lastly, we talk about emotions. It's estimated that up to 1 in 4 people experience pain but have not had an injury. Injury and pain are not synonymous. In fact, these thoughts are outdated and follow Cartesian theories. Emotional overload due to various stressors in your life can also result in pain. We demonstrate how various emotional stressors can activate the alarm system and result in pain. Now you might be saying, I don't have time to do all that. That's fine. No one expects you to. In fact, nobody expects you to completely abandon all old practices either. Just reframe them. Dr. Sandy Hilton in Chicago had just come back from the World Congress of Pain and really hits home with this next comment. So really, that sounds very esoteric, but really it needs to be how we frame it. Not necessarily changing everything about what we do, but it's the how we do it. How we explain things, the words we use, the actions we take, the explanations we provide, yes, give them the interventions that that they need, but frame them in a light that has hope, that has better understanding, that they can grasp, that they can change. So to summarize everything about neuroscience education, if we can help patients understand, if we can understand first of all about pain better, and help our patients understand about that, it'll help to reduce pain, increase function, reduce fear and catastrophizing, improve movement, and change brain activation patterns. So I have the references here. If you want them in visible format, I would be happy to provide them. What questions do you have? All right.